Welcome to Charter California Edition. My name is Brad Pomerance. We are joined by Dr. Ed Hernandez. He is a member of the California State Senate. You head up the Health Committee, is that right?
Yes, Chair of the Senate Health Committee.
And you are an optometrist yourself.
That is correct.
And I plan to go to your practice one day, no doubt. My eyes are failing me in my 40s. But be that as it may, I want to speak with you about the Affordable Care Act. And that is what we know as Obamacare. And as part of the Affordable Care Act, we are going to see more people, more individuals being able to access primary care services.
Correct.
Explain why that is.
Well, with the implementation of the Affordable Care Act, we are going to have a huge capacity issue, but more importantly, a workforce shortage. Because right now, the number of primary care physicians in the state of California, there's a distribution problem. Few of them go to rural communities and inner city.
And I want to talk about that, but before we get there, let's kind of lay the groundwork. With the Affordable Care Act, the ultimate goal has been to get more people into primary care and out of the emergency rooms.
That is correct.
And so I guess with the combination of the individual mandate, the exchanges, and then the Medi-Cal expansion, there are more people that can go to primary care.
Right. And what we're going to end up doing is we're going to be mandating everyone purchase health insurance. 4.5 to 5 million new Californians are going to be available, and half of those or so are going to be in Medi-Cal. We need to make sure that, number one, they have access and they have somebody that they can see to provide care.
And so let's talk about the dearth of doctors, because California is notorious for it. You look at federal guidelines, and as a general proposition, the federal government is looking at 60 primary care physicians, or 60 to 80 primary care physicians for every 100,000.
Right.
We're not meeting those goals in the majority of our counties.
Right. Only 1/3 of the counties meet that national average. The rest of them don't. And also, an interesting statistic in California, about 25% of the primary care physicians in California are over the age of 65.
Right.
And they're going to be retiring very soon.
And particularly hard-hit areas, the Inland Empire, the San Joaquin Valley, and so it can be quite a challenge. You are carrying some bills that would expand the scope of practice for certain medical professionals to bridge what we know as that provider gap.
Yes, that is true. What I am doing is we've had a series of workforce committee hearings over the last few years, gathered all the data information, and to me, the absolute most important thing is looking at professions that meet, first of all, 3 criteria.
Okay.
Number one, that there is a national standard or a national test that they have to take. Second, it's proven in other states and safe and efficient, or in some other system, like the federal government or the Indian Health Services, or within the state of California, within closed systems. But third, and what's important, is the fact that there's an independent board of the state of California under the Department of Consumer Affairs that oversees, regulates that profession to protect the consumer, and that's the absolute most important thing.
So let's talk about a few of those professions. There are physician's assistants. I've been treated by them. I've had some skin conditions treated by PAs. Nurse practitioners, pharmacists. My dad's a pharmacist. He's given flu shots, for example, and optometrists. You're an optometrist yourself. I've seen one. Talk to us about those 4 categories and how you or other members are carrying bills to allow those individuals to act at some level as primary care physicians.
Well, I mean, the PAs, 2 other members in the Senate are going to be carrying those bills mainly to address the shortage with regard to the number of patients that they're allowed to see within that system. The ones that I'm carrying are going to be the nurse practitioner, the optometrist, and the pharmacist. Going back to what I said about the minimum criteria, these 3 professions I believe will meet it. But what's most important is these pieces of legislation are going to address the fact that we'll only allow them to do what they're trained, nothing more, or make sure that patient safety, but more importantly, that they interact within the medical community or with physicians as well.
But the key point is, for example, under your bill, nurse practitioners would be allowed to set up independent practices.
That is correct.
And so, for example, when I went to the PA, I know that's a separate bill, but similar, I was seeing her under the guise of an office where there was a medical doctor. So why do you believe it's important that these nurse practitioners be allowed to open up independent practices and not be under the purview of an MD or OD?
Well, what this bill is going to address is to allow nurse practitioners what they're currently allowed to do in California under the auspice of a medical doctor to practice independently. And first of all, that there are 17 other states that allow them to do it,
really?
that have been shown to be safe, effective, and completely been able to provide that care. But here's the reason why we want to allow them to do it independently.
Please.
Because of the distribution problem we have. Okay, nurse practitioners are only allowed to practice within the confines of a physician. Physicians aren't going to the inner city. They're not going to the rural communities.
Right.
So now if you have providers that are willing to go to those communities, they can set up, see patients, and collaborate with a medical group or a medical home.
So talk to me about the scope of practice of a nurse practitioner. What can he or she do within the confines of your legislation?
Well, all primary care entry points, which is obviously everything from colds to dealing with diabetes, high blood pressure, and they wouldn't be doing anything that's without of their scope or anything that they're not doing. Immunizations, day-to-day flu shots, and there's actually specialty nurse practitioners that work with specialty clinics, but those are much more advanced in what they do. But just the day-to-day, what you would see in a family practice, federally qualified health center, a clinic.
And presumably their rates would be lower, which is part of the goal of the ACA.
Well, the goal of the ACA is to make sure that everyone has access to health care.
Right, but we need to somehow contain costs. I'm not saying contain services per se, but at a certain level for the ACA to work,
You want to reduce costs.
Yeah, clearly.
Right.
PAs as well, under the bills being carried by Senator Monning or Senator Pavley, they would be able to open independent practices?
No, they will not. They will still be under
Why?
the auspice of a physician. The PAs, their association, just wanted to change some of the regulatory process, but they will not be allowed to be independent.
Do you have a sense why? I know it's not your bill. But
I couldn't tell you. I know we've discussed that with them, but they would prefer just to stay the way they are and just make some internal changes.
And allow them to expand their scope?
No, not necessarily expand their scope, but number one, be classified as a provider for billing purposes. Allow a physician and a PA to see more patients under a medical or under a health insurance plan.
So intuitively, even though my dad's a pharmacist and you're an optometrist, the PA and nurse practitioner scope and expanding it feels right. Mm-hmm. Convince me on the pharmacist side and on the optometrist side.
Well, let's start off with the pharmacists. I say that pharmacists are the most overeducated and underutilized professionals in the country. Now, a pharmacist that's graduating now is graduating with a 4-year undergrad degree and 4-year postdoctorate. It's called the PharmD degree.
My dad didn't have to, but he's in his 70s.
And the postdoctorate degree includes patient interaction, includes residency programs. I met a clinical pharmacist that works in a federal qualified health center in the rural counties, and they couldn't find an internist or a GP to come in once that individual retired. They set up what's called a standard protocol with a physician in a city further away. Telehealth, telephone, sort of similar to what a nurse practitioner does. That pharmacist is seeing all of those primary care entry point patients. They are doing clinical rotations. They're seeing patients. They're diagnosing. And who better than to adjust medications and understand medications than the pharmacology that they learn in pharmacy school?
They understand contraindications. Yes. What about the optometrist?
Okay. Let's talk about optometry. Optometrists are already independent practitioners.
Yes.
We can diagnose, treat all eye diseases. I have a DEA number. We can use antibiotics, oral, topical, everything related to the eye. And there are more eye exams in this country than there are physicals. And optometrist is probably one of the very few professions where you have first-time encounters of individuals who have never been in the healthcare system.
And as I understand it, you can look into someone's eye and possibly see signs of diabetes?
Yes. I'm going to give you a typical example of what happens every day in my type of practice.
20 seconds.
Okay. A patient, 55 years old, never been seen, and the only reason why they came in to see me is because they failed their vision test for the DMV to get their license. Take the history, dilate their eyes, run tests, they're diabetic. We can see them and start interacting with them immediately in a medical home.
You want to be able to offer insulin, for example?
Not insulin, because insulin, I believe, is more complicated. When you have a diabetic that's type 2, basic control, high blood pressure, and cholesterol.
He's Ed Hernandez. I'm Brad Pomerance. This is Charter California Edition.
In 2011, how much money was expended on healthcare in the United States? 1.9, 2.7, 3.2, or $4.1 trillion? In 2011, spending on health care in the United States totaled $2.7 trillion.
Welcome back to Charter California Edition. I'm Brad Pomerance. We are now joined by Mark Uffler. He is the regional CEO of Prime Healthcare, which is what?
Prime Healthcare is a healthcare provider made up of 23 hospitals now. We are in 6 states. We were started by a physician, Dr. Prem Reddy, originally from Victorville, and mostly in California,
right,
and has expanded over the last several years.
So there's no doubt, sir, that your patients and other patients throughout California and the nation are a little, I'll say nervous about healthcare delivery as we march into 2014. The Affordable Care Act is the law. There's no doubt about that. The Supreme Court upheld it. President Obama was reelected. And so where we stand today is that every single individual is required to get health care or they face a tax penalty. Explain what that really means to you and me.
Well, it's a bold thing in general to say that every individual is going to have health care. I think when the president decided to go down that path, he opened a door that we weren't all sure how he was going to get us through that door.
Right.
But essentially, you have a significant. I think the best thing to do. Let's talk about insurance.
Please,
and how
obviously
how we have grown accustomed to being insured by. As we've grown up, and you look back, and generally, if you had insurance, it was either through most of the time, it was through your employer, and that was just traditional HMO, PPO insurance. There's a significant population, 65 and older, that we call the Medicare population. That doesn't change. Those patients will still stay on Medicare. The bigger population, the ones that we're most concerned about, the Medi-Cal, nationally Medicaid, California Medi-Cal. That population is significant in California and significant throughout the United States.
And let's talk about the Medicaid, Medi-Cal population, because as you know, the U.S. Supreme Court did have a specific ruling on that issue. And what the court had said is that the Obama administration, or the federal government more specifically, could not force states to expand Medicaid in order to get additional federal dollars.
Correct.
Some states are not expanding. California is. They've accepted the federal dollars, and as a result, they are expanding the Medicaid pool. So what does that mean for Californians? What does that mean for Prime Healthcare?
Well, essentially what's happening is you're taking the Medi-Cal population, which California is a mature Medi-Cal population. It's a mature market. Many states, for example, in Nevada, it's still fee-for-service Medi-Cal, meaning basically the patient is on Medi-Cal, they go to a provider, and there's a fee, and it's not discounted. It's just whatever the Medi-Cal state fee is, which is about $1,400 a day if you're hospitalized. In California, Medi-Cal is heavily managed. So you have these groups like Cal Optima, Inland Empire Health Plan, LA Care, Molina. They actually take that Medi-Cal population and they manage it, much like an HMO.
And what's interesting is we have faced a budgetary crisis in California, and our current governor has been looking to decrease Medi-Cal reimbursements. A court recently upheld his ability to decrease reimbursements, and you know as well as anyone that doctors are reticent to take Medi-Cal. Some are refusing to take Medi-Cal.
They don't want to take Medi-Cal because of the reimbursement, and often it doesn't cover their costs. And then you add to it the fact that you're trying to change the behavior of this population. This is not a population that grew up with traditional health care insurance. So they're not used to using primary care physicians. They want to go to the emergency room.
But that's really the key in order for the Affordable Care Act to be successful, as I understand it, is that we need to re-educate our population that the emergency room is not the first step. It's the last step. And so part of what the ACA is looking to do is, as I said, push people into preventative care, primary care. So that begs the question, as part of this underinsured or uninsured population, some will qualify for the Medi-Cal expansion. Others, though, may be able to enter what's known as the exchange system.
Correct.
It's called Covered California. That, to many, is the most promising, I guess you could say, especially for those that don't get insurance from employers.
It's promising. It's just untested
and unknown.
And unknown.
Right.
And so you have the concept is this exchange, this California exchange, will have tiers of coverage that the consumer can buy. And then you have the consumer that can say, well, I really don't want to be part of the exchange. I just want to opt out. Well, there'll be a penalty for that.
Right.
But unfortunately, the penalty will be so low that it's not a disincentive for them
We do
not
know
to get insurance.
that has been a significant criticism, that the penalty is not enough of a penalty. Although, as I understand it, the penalty does ramp up, so it becomes more of a disincentive. But that being said, and really educate me and our audience, if you may, part of the problem for the small business person or the individual who doesn't get insurance through their employer is they have no bargaining power.
Correct.
With insurance companies. And we know the Anthems, the Blue Crosses, they have been engaging in double-digit increases for years on these folks. But if you're part of an exchange, the exchange is the actor that will create the bargaining power.
It's a broker, so to speak.
Right. And so are you bullish on this?
I think it's too soon to be bullish on
Fair
anything.
enough.
I think it's really important to watch this evolve, be a player at the table, be a participant if asked to participate. I know we're looking at some of the low-income health plans out there,
right,
trying to partner with counties and trying to determine, you know, where we fit into that network.
You wouldn't bid per se to be part of an exchange because you're not an insurer.
We're not an
right.
insurer.
And so the providers don't participate per se.
Correct.
I do want to ask you, though, about a challenge we face in California, and that specifically is there is a dearth of primary care physicians.
Correct.
There are some counties that just don't get anywhere near the average that is expected by the federal government. I know in your background you had been a physician's assistant, a PA. I've had wonderful experiences with PAs myself. There are moves to empower PAs, nurse practitioners, pharmacists, optometrists to have more primary care responsibilities. I understand that Prime Healthcare hasn't taken a position on that specifically, but in a very broad sense, if I can speak to you, what is your notion of this idea that we need to empower healthcare providers beyond just the MD or the OD?
Well, the only way that the Affordable Care Act and the Obama plan is going to work is if you increase the network of providers. And because of the shortage of primary care physicians in particular markets, there really, it will be no alternative but to have extenders.
And I know that you serve significant portions of the Inland Empire.
Correct.
And the Inland Empire has been specifically hard hit by a lack of primary care physicians.
I can give you a firsthand example.
Please.
You know, before I worked for Prime Healthcare, I did a little stint working at Colorado River Medical Center down in Needles.
Oh, so you know.
No primary care physician in the community.
None.
None.
Not
Zero.
one, but zero.
Zero.
Wow.
The closest primary care physician was across the river in Arizona.
What do you do, especially crossing state lines? Healthcare is such a tricky issue.
There is really no answer but to try to find extenders, either nurse practitioners or PAs to go down there. Obviously, those kinds of communities that are underserved are going to have extenders in order to survive. Telehealth is a big issue. It's something everybody's looking at. We were doing some of that. We were working with Loma Linda and with the County of San Bernardino to provide telemedicine coverage down there. But again, you have to have some provider on site that can actually initiate the contact with the telehealth providers.
What would you tell our viewers as we enter into 2014? How would you educate them?
Well, I think the biggest education I think everybody's going to have is that the emergency room is not going to be your place of primary care service. It basically impacts the emergency rooms to the point where they're inefficient. And I think that they're going to have to be open-minded about shopping for insurance. They're going to have to be informed consumers for the first time.
Clearly. Okay, his name is Mark Uffler. He is the regional CEO of Prime Healthcare. Thank you so much for all your insight. We really appreciate it.
My pleasure.
My name is Brad Pomerance. You're watching Charter California Edition.
According to the Centers for Disease Control, 19.4% of California did not have health insurance in 2012.
Welcome back to California Edition. I'm Brad Pomerance. He is back. He is the dean of UCR's new medical school. He is victorious. His name is Dean Richard Olds. Congratulations again on accreditation.
Thanks.
What a huge victory. You told me something, and I want you to tell our viewers. How many medical schools have seen their accreditation turned down 1 year, and then they get it another year?
Well, now exactly one, us.
Exactly.
But prior to that, there had never been a medical school that had actually done that. So obviously, that was a big hill to climb last year, and we wouldn't have been able to do it without our community. Right. Basically, when we were turned down by the state, the only way to get the school open was to have basically everyone in the community step forward, and that's what we did.
And when you say turned down by the state, the ultimate reason for the first denial was the state withdrew funds that they had promised to UCR Med.
June 28th, the governor dropped us out of the budget.
Yeah.
So that was the kiss
That was
of
problematic.
death. Yeah.
And so over the last year, you, along with Chancellor of UCR Tim White, went on a massive fundraising campaign.
Yes, we
and
did.
It was successful.
We raised $100 million, but most importantly, it was $10 million a year for 10 years. So it wasn't just the magnitude of the money.
I see.
People made 10-year commitments, and that's very important because ultimately we didn't have as much money as many other starting med schools, but the fact that we had a 10-year commitment and so many people in the community participated allowed us to get accredited with a smaller budget than most med schools.
But what about the state? Because you still need a funding stream from the state of California.
Well, we're back knocking
Right.
at their door. We have asked the state for $15 million in ongoing support.
Is that a lot in the
No.
scheme of things?
Well, I'll give you an example. Austin, Texas is starting a brand new medical school right now.
Right, okay.
Austin, Texas had a tax levy to raise $25 million a year forever, and they received another $25 million from their system. So they're going to be opening their new medical school with $50 million a year on an ongoing basis.
Not fair.
And the existing UC medical schools, all get considerably more money than that in state money, and they have profitable operations because they've been in existence for decades.
So, good news or bad news, I'm not sure. We have two new members of the California State Legislature representing Riverside, Jose Medina and Richard Roth. Where are they in this calculation?
Well, clearly that's good news for us because both of them actually ran on a platform of getting the School of Medicine funded. And when they were sworn into office, they were allowed to submit one bill. They both submitted a bill to provide $15 million in ongoing support. So
that works.
It's hard to have too much better support than that.
And how does the passage of Prop 30 play in the calculation? Because Prop 30 gave money to K-12, K-14, and the UC system and the CSU system.
Well, if Prop 30 had gone down, I think there's no way we get any money. There would be no way for the state to give us new money when they were simultaneously cutting everybody else. So I think it would be fair to say Prop 30's passage allowed for the possibility of us getting funded. And now we just have to get over that next little hill to get that money.
Now, I think it's fair to say we are incredibly proud that Tim White has been awarded the position as, is it Chancellor of the Cal State system?
Actually,
or President?
It's the reverse of the
it's President of the Cal State
UC system.
The sad part is he's leaving UC Riverside. How do you feel about that, sir?
Well, I found out that I was accredited, and you can imagine
elation.
The elation of that. And I learned that on one day, and the very next day, Tim called me and said he was taking this job. So
rascal.
Up and then crashing. But what a fantastic opportunity. Those lucky people at Cal State getting Tim.
And it's the entire system.
It is the entire system. But, it would be difficult to replace a person who not only was a steadfast supporter of the med school, but is very knowledgeable about med schools. He had been on a medical school faculty in Michigan. So, hard to do better than a fantastic boss.
Now, clearly. So we'll see what happens with the new chancellor. We are heading into the fall of 2013, which will be your first medical school class. So that means that you are accepting applications as we speak. How's it going? Well, I know you don't know because technically deans can't be involved, but generally speaking.
Well, remember we had to start late. Because of this process, most medical schools started accepting applications in the summer. So we weren't accredited till October, so we got into it late. So many students, when they applied during the summer, we weren't in the national computer. This is a national process. Having said that, we're going to take 50 students, 24 from our own campus, UCR.
UCR undergrads.
Undergrads, and 26 that can come from anywhere. And we already have over 2,000 applications. So
is that a good number?
That's a lot of applications.
Is it more or less than you expected, given the late start, given new campus?
I was pleased with 2,000.
Right.
We could have, if we hadn't made it pretty clear that we wanted to recruit students from California,
right,
and more importantly, inland California,
right,
we probably could have easily gotten 5,000 or 6,000 out-of-state applications. But I think, given our mission, not too many should apply.
Is there a state residency requirement?
Not a requirement, but we are explicitly training doctors to stay in inland Southern California. So what's the odds that I can get a student from New York to stay?
Of course.
In fact, I would argue 2 equally qualified students, one from San Francisco and one from Coachella. The student from San Francisco, I'm going to have a hard time getting them to stay, even if they go to my med school. I have a fighting chance of getting the student from Coachella to stay.
But here's the good news. Many of the new medical schools, they haven't started residency programs. And you've tutored me to know that where a doctor ultimately lands is either their hometown or where they finish their residency.
Right, the residency.
Not where they finish med school.
Right.
So if UCR didn't have a residency program, your chances were slim that they would come back to inland California. But you are starting or have started?
Have already started. So, yeah, it's not that we'd only be halfway there. About 40% of the decision is where you come from, equally divided between where you're born, where you went to high school, where you went to college, by the way.
Okay, got it.
And then about 40% of the decision is where you finish your training. So we're building graduate medical education programs. Those are the specialty residency training opportunities and we already have an existing family medicine program at the county hospital. We started 3 years ago, when I first came, a general surgery program between Kaiser and the county hospital. Just this year, we started a primary care general internal medicine residency between the county, Riverside Medical Clinic, Riverside Community Hospital, and Kaiser.
And there are 3 more you're looking to start.
And I will start a primary care pediatric residency, OB residency, and psychiatry residency in the next 3 years.
Why those 6 areas of specialty?
Those are the areas in greatest shortage. So I don't think you'll see us build a plastic surgery residency.
Plenty of plastic surgeons.
There's probably plenty of them.
Right.
So it's very important not only to have residencies that have the shortest numbers, but the size of the residencies have to be comparable to the deficit. So the largest residency programs in numbers will be the primary care residencies, because that's where we're so far behind.
And you are not far behind in terms of facilities. Your UCR medical building is open.
Yes, actually, we got 2.
It's open.
We got a brand new building open, and we just refurbished another building, and it's open just a couple weeks ago. And so we actually have the physical plants, by the way, all paid for. Those buildings are paid for.
By whom?
Over the years, in the wisdom of the University of California, Riverside, they basically put us into the master plan. And just like the rest of the buildings, they were built with this medical school in mind.
And they were also built knowing that we were in the 21st century, not in the 20th. And so they are filled with smart devices, smart technology. Explain that.
Well, the way we train doctors, we do a lot of different things than when I went to med school, and we've chosen to retain a few things that other med schools may not choose to. So on the new end, we use simulation, if you will, high technology. We actually have electronic mannequins. They're quite expensive, about $300,000 each.
It's worth it.
But just like an airline pilot will take off and land a plane thousands of times before they actually get in a real plane in simulators, we actually have these electronic simulators, patient simulators, so that both our students and actually groups of professionals, nursing students, pharmacy students, can actually be in critical medical situations and practice what they do before they ever see a real live patient. We also have another wonderful, I think, innovation in education. We actually have professional patients, often actors or retired physicians, who pretend to be patients. And the students come in and take a history and physical. It's all recorded on tape. And then the students are graded by their patients. What a wonderful idea from the very beginning.
I have to say, I have rarely met an academic who is as passionate about their job as you are. And I know UCR Medical School is just the better for it. I am so excited for you. I congratulate you. I can't wait to meet the 50 students that will be joining you in fall of 2013. His name is Richard Olds. He is the Dean of UCR's Medical School. I'm Brad Pomerance. Thank you so much for watching Charter California Edition.